Thank you, Chairman. So it's my job to make sure that we recover from that assault on precision medicine by the previous speaker. And I submit to you that, and I would agree with Dr. Pulowski, that precision medicine is a dream, but it's a goal. But without dream, nothing can ever be achieved. But this is a first step in achieving where we want to be. And this was the step where oncology and cardiovascular diseases were like 10, 15 years ago. And if they didn't think about it this way, we wouldn't be here on precision therapies for those diseases. So I think nevertheless, although it's a dream at the moment, it's a dream in the right direction that one day we hope that the dream will come true. So with that, I'd like to go over the concept of precision fluid balance and try to introduce you in the first step in the direction towards how can we obtain precision in net ultrafiltration intensity. This is a concept that we don't think about it, we do it, but I'm going to try and convince you by the end of this talk that it's important to think about it, and it's a first step in trying to think about how we apply precision medicine towards fluid control or volume control in critically ill patients with fluid overload. So in terms of disclosure, I've received several sources of funding, but nothing, I don't have a conflict with anything that I'm just going to say at the moment. So if you look at the fluid overload, the prevalence of fluid balance in critically ill patients, so this is a data from University of Pittsburgh Medical Center looking over about 18,000 patients or so, in which we looked at cumulative fluid balance on a daily basis from the time of ICU admission up until the ICU discharge. As you can see here, about 45% of the patients were positive fluid balance, defined by a cumulative fluid balance greater than 5% of fluid overload. And this is important to think about because 500 cc or a liter fluid overload is not the same in a patient who's 100 kilograms as opposed to a patient who is in 50 kilograms, okay? So they have a very differential effect. And if you don't think of it that way, then the outcomes are going to be very, very different. And how you manage those patients would also be very, very different. Another important thing that we found in the study is that not all patients are either positive or negative. And then there is a third group of patients in the ICU who sit down there who are euvolemic. And we defined euvolemia as a group of patients who were able to regulate their fluid balance individually between 0 to 5% of body weight from the time of ICU admission. And so we asked the question, since many prior studies have looked at what is the relationship between fluid overload compared to patients who do not have fluid overload on outcome, we asked the slightly different questions. We asked the question, what is the influence of fluid overload compared to patients who remain euvolemic in the ICU, as well as compared to patients who remain in a negative fluid balance in the ICU. And so you can see here the incremental increase in mortality between fluid overload and the risk of death, suggesting that clearly fluid overload is associated with increased risk of death. Furthermore, the hazard associated with fluid overload is not constant over time. It kills you at a higher risk early on after ICU admission, as you can see in this cartoon, where the solid line indicates the hazard ratio. Any hazard ratio above 1 means that fluid overload or positive fluid balance is associated with increased mortality, and the dotted lines indicates the 95% confidence interval. And you can see that days after ICU admission, the hazard ratios are really around like 1.8 to 2, suggesting there's a substantially higher risk of dying from fluid overload in the first few days after ICU admission. Although this risk comes down over time, but nevertheless it sort of remains high throughout the 1 year. Suggesting that fluid overload at any point of ICU after ICU admission is bad. And these effects are independent as it persisted after we adjusted for many of the patient characteristics, process of care characteristics, and so on. So furthermore, we looked at what happens when you compare these patients in the short term to a long term, like in a 1 year mortality. You have a 2 or 3-fold increased risk of death when you compare patients with positive fluid balance with that of the negative fluid balance. So how much are these patients really fluid overloaded? So if you look at these patients, especially the ones who are on CRRT, or RRT, for example, more than 2/3 of the patients, 75% of the patients, at least in our institution, are fluid overload by the time they receive renal replacement therapy or get on to renal replacement therapy. So they receive about 5 liters of fluid within the first 24 hours. They are 7 liters positive here within the first 72 hours. By 7 days, by week, there are about 10 liters positive. And you can see there's a substantial increase in mortality, about 46 or 47% in hospital mortality. And this risk increases to 60% by 1 year when you compare patients with positive fluid balance to that of negative or even fluid balance. One interesting thing that we found was that when you take patients with positive fluid balance and you put them on RRT, there is an attenuation of risk. So in other words, in the prior graph that I showed you, you can see in all comers, fluid balance was associated with a positive fluid balance when compared with even fluid balance was associated with increased risk of death. So this cartoon actually shows an interaction analysis between positive fluid balance compared with even fluid balance on patients who received RRT compared to patients who did not receive RRT. So what happens is that when you take a positive fluid balance and you start RRT, immediately the hazard of death immediately decreases. So anything below the 1 shows that positive fluid balance is actually protective for mortality if you put them on RRT. In other words, RRT modifies the effect of positive fluid balance on the long-term risk of death. So that's what the study showed, and we were intrigued by this. And this is not a new thing. We've all put patients on RRT. But one of the things that we then led to ask the question, what is that RRT does in terms of modifying the risk? Obviously, we clear solutes, we clear fluid. And if this is fluid that we clear that results in improvement in outcome, then how much? Then it automatically brings you to the question, how much should we clear? As anything else in life, there should be a dose-response relationship if there is if anything is going to be related to the outcome. And this is the data from the renal trial that was published by Bellomo and colleagues as a post-hoc analysis. And what they found was patients who went on renal replacement therapy were on average about 500 mLs negative fluid balance throughout their ICU stay. And so that differentiated survivors and non-survivors. And we sort of asked the question, is it really the negative fluid balance that drives the outcome, or is it really the ability to maintain the negative fluid balance that drives the outcome? Because 500 mLs negative fluid balance, and if you look at the effect size, it's about 60% reduction in mortality by 90 days, and it's difficult to imagine that 500 mLs negative fluid balance has got such a huge effect size. Nevertheless, we wanted to then understand what is the relationship between the dosing of fluid removal, or so-called the intensity of fluid removal, on outcomes on patients who receive ultrafiltration. So this is a nice cartoon that illustrates the concept of dosing in critically ill patients receiving renal replacement therapy, where it's fairly well known whether you use CRRT or IHT at the moment, that you should be, if you're using CRRT, you should be delivering a dose of at least about 20 mLs per kilogram per hour of effluent fluid. If you're using hemodialysis, then the data suggests that you should be over time average urea concentration, KT over V, of at least 1 to 1.2. Why? Because less than that is considered suboptimal and is thought to be associated with lower survival, although the data is not that very strong. It's now fairly established that that's really the best practice window, or so-called the dose-independent range, when we think about solute. And yet, we do not have any recommendations or any data to suggest what should be the dosing of fluid removal or the intensity of fluid removal to gain mortality benefit. In other words, if you are removing 50 mLs in a 50 kilogram patient for 24 hours, is that the same in removing 50 mLs in a patient who is 125 kilograms? They're different. Okay, even though you're removing the same fluid. In other words, we're sort of blindly removing fluid, and sometimes we don't even think about, what the percentage of fluid accumulation or the amount of body weight and so on in terms of removing fluid. So we wanted to understand what is the effect of dosing. Why this is important? Because each day you spend on fluid overload, it has a direct effect on various organ system dysfunction that you have, as illustrated by this nice cartoon where it affects every organ system in the body, where fluid balance is associated with increased risk of delirium, in the heart is associated with cardiac arrhythmias, in the lung pulmonary edema, impaired gas exchange, in the gut it's associated with decreased tolerance to nutrition, and tissue edema, poor wound healing, and so on. And there's also emerging data to suggest that fluid overload and tissue edema associated with impaired recovery of renal function in critically ill patients. So what about if we removed more? So why not we remove more? Okay, so we take too much fluid out and let's see what happens. Well, we have to be very cautious about that because this is the data from hemodialysis patients looking at outpatient hemodialysis, looking at the intensity of ultrafiltration and outcomes, where they looked at less than 10 ml per kilogram per hour of ultrafiltration and compared that to 10 to 13 ml per kilogram per hour of ultrafiltration and greater than 13 ml per kilogram per hour of ultrafiltration on both all-cause mortality and cardiovascular mortality. As you can see here, compared to less than 10 ml per kilogram per hour of fluid net ultrafiltration, patients who received greater than 13 ml per kilogram per hour of ultrafiltration were associated with increased risk of death, all-cause mortality as well as cardiovascular mortality. It's an observational study, but nevertheless, it sort of points to the authors in this paper argue that over-removal of fluid results in cardiovascular stress that subsequently causes ischemia, inflammation, end organ dysfunction, target organ dysfunction that puts you at a higher risk of all-cause death as well as cardiovascular mortality. So it's important that we get this right. What happens if we take too much fluid? And we know there's fairly good data out in critically ill patients that if you cause hypotension during dialysis in critically ill patients, which is about a third of patients, observational studies show a third of patients will develop hypotension during fluid removal in the intensive care unit. There's a substantial increase in risk of death. The point I'm trying to make is that it's important to be right, but yet we don't know what is right. What is right for the patient? Where is the data to guide us what we should be doing in the ICU? And so we wanted to look at that. And so we asked the question, is there an association between how much we remove, defined as net ultrafiltration intensity, and risk-adjusted 1-year mortality among critically ill patients who have fluid overload after ICU admission? And we define net ultrafiltration intensity in ml per kilogram per day as the total amount of fluid removed using RRT divided by the patient's admission weight in kilograms and the number of days that they received RRT. And here's the flow of patients and then the study population. We started with about 45,000 patients, and we excluded a number of patients in whom the weight wasn't characterized, the fluid balance wasn't characterized, patients with end-stage renal disease, chronic dialysis, and patients who died within the first 72 hours of ICU admission, because we hypothesized that if something kills you within the first 48 to 72 hours, it's the acute illness as opposed to exposure to fluid that is likely. And we also excluded patients who had low severity of illness in whom they're coming to the ICU just to get extubated to go out of the ICU. So we didn't want to include those patients. So we excluded those patients. And we also excluded patients who were not fluid overloaded, who had less than 5% of body weight, and who never received renal replacement therapy. And so we ended up with this analysis cohort of 1,000 patients or so. And so here you can see the distribution of the high, moderate, and low intensity ultrafiltration. Okay, so we define low intensity ultrafiltration as those who receive less than 20 ml per kilogram per day, moderate as 25 to 20 ml per kilogram per day, and high as greater than 25 ml per kilogram per day. And shown in this cartoon is this association between the net ultrafiltration intensity and mortality. And on the extreme right-hand side, you can see that lower net ultrafiltration intensity was associated with increased hospital mortality. So this is hospital mortality. On the other hand, there seems to be at least some evidence to suggest that higher intensity ultrafiltration is associated with better outcome. We arbitrarily divided this as less than 20 to 25, and greater than 25 ml per kilogram to try and see what is the relationship between the ultrafiltration intensity and outcome. And these are the baseline characteristics. I wouldn't expect you to read all of these things, only to prove the point that there were large imbalances in the baseline distribution of several of these variables. Especially you can see that, the sex, the comorbidities were somewhat imbalanced, especially liver transplant. But I would point out to you, though, the Apache score, the severity of illness, was very similar across 3 groups. And then the mean arterial pressure, as you would expect, which is one of the most important variables that we think about when we remove fluid, was actually, as you would expect, that was lower in the patients who received low-intensity ultrafiltration when compared to high-intensity ultrafiltration greater than 25 ml per kilogram per day. But however, you can see that the use of vasopressors were around the same. So in other words, there was no difference in cumulative vasopressor dosing among the 3 groups at the initiation of ultrafiltration. So these are data at the time of ICU admission prior to initiation of ultrafiltration. Now, if you look at what happens during treatment with ultrafiltration, as you can see that patients were overall had a higher cumulative fluid overload before initiation of RRT. So they were about 21 liters positive compared to less than 20 ml who were less fluid overloaded, as you would expect. Patients who had high intensity ultrafiltration had a higher mean arterial pressure and they required less vasopressors. This is after the initiation of ultrafiltration when compared to less than 20 ml per kilogram. As you would expect, patients who received high-intensity ultrafiltration, who received CRRT, IHT, and CRRT and IHT, both of those had higher amount of fluid removed during treatment. If you look at the hospital length of stay, there was not a lot of difference between the moderate and then the high intensity. However, when compared to low intensity ultrafiltration, the low intensity ultrafiltration had a lower hospital length of stay because of higher mortality. However, we found a substantial difference in the hospital mortality as well as the 1-year mortality among patients who received high intensity ultrafiltration compared to low-intensity ultrafiltration. There was some trend towards better renal recovery among patients at 1 year. So we defined renal recovery who were alive and independent of dialysis at 1 year. But when we looked at only at survivors, there were no differences. So these are the risk-adjusted odds ratio for exposure to high-intensity ultrafiltration greater than 25 ml per kilogram per day on 1-year mortality compared with low-intensity ultrafiltration defined as less than 20 ml per kilogram per day. As you can see that the high-intensity ultrafiltration, after adjusting for 30 different variables, we ran 3 different analyses and several sensitivity analyses to confirm this finding, were independently associated with lower risk of death. In other words, this 25 ml per kilogram per day was associated with treatment benefit after adjusting for all characteristics, including the severity of illness, hemodynamics of the patient, as well as the vasopressor dose when compared to moderate as well as low-intensity ultrafiltration, when compared to low-intensity ultrafiltration. Furthermore, we also define the intensity as every 5 ml per kilogram 5 ml per kilogram per day. And you can see, compared to 0 to 5 ml per kilogram per day, a per 5 ml increase in ultrafiltration intensity had a trend towards a lower risk of death. The reason why confidence intervals are wide and it goes beyond 1 is because we had lower number of patients within those subgroups of bins of patients within each of those categories. But nevertheless, the trend seems to indicate there is a benefit to higher intensity ultrafiltration. So we then ran a propensity matched analysis in which we took each patient with a high intensity ultrafiltration defined by greater than 25 ml per kilogram per day and then sort of tried to match them with less than 20 ml per kilogram per day, and we found the same thing, that there's a substantial benefit to intensive ultrafiltration. And then we asked the question, how long does this benefit last? And you can see in this GRACE model, you can see this benefit associated with high-intensity ultrafiltration seems to last at least for 35 days, when you look at it. But the highest benefit is earlier after ICU admission and initiation of ultrafiltration. So why this might be? We think that it might be because of, by reducing fluid overload, it reduces the incidence of organ dysfunction that alters the trajectory that fluid overload puts you in that drives the mortality benefit. Now, we ran several sensitivity analyses. We looked at only up to fluid balance, up to 72 hours after the initiation of RRT. We changed the threshold moving the threshold up, in which we defined high intensity as greater than 30 ml, and then moderate intensity as 25 ml to 20 ml, and low intensity as less than 25 ml, and we found the same thing. And then we moved the threshold down. We found the same thing. And the subgroup, we then performed a subgroup analysis looking at patients who had more than 20% fluid overload. And then we also tested this in patients who only received CRRT in this cohort. And what this translates into is about 1 ml per kilogram per hour of fluid. So if you want to have a mortality benefit, then the data seems to suggest that 1 ml per kilogram per hour in CRRT seems to have a mortality benefit. The limitations of the study is an observational study design. It's single center study. We were unable to distinguish whether low intensity ultrafiltration is because the clinicians prescribed low amount of fluid removal, or is it because of some patient intolerance factor to fluid removal that fluid was not removed, or like where nothing was done, patient fluid was never ever removed at all. But nevertheless, I would submit to you that there is a dose-response relationship between intensity of ultrafiltration and mortality. To our knowledge, that this is the first time we've demonstrated, or at least anyone has demonstrated in the literature, showing that the intensity of ultrafiltration, the amount you take, directly relates to the outcome. We think that 25 ml per kilogram per day is the sweet spot, that if you want to be compared with less than 20 ml per kilogram per day, the greater than 25 ml per kilogram per day is associated with decreased risk of death at 1 year. And we think that these are independent of severity of illness or hemodynamics. And we think that the benefit lasts up to 35 days. One thing the study illustrates is that the importance of dosing doesn't apply just to solute control. It also applies to fluid control. And that's why it's important, because in the ADKI meeting, Professor Ronco clearly said the dosing or any concept of RRT use has to be a holistic approach, not just looking at solute clearance, not just looking at fluid clearance. It has to look at all the metabolic control of parameters as a whole. But using this definition, in our cohort, about 40% of the patients received less ultrafiltration, in other words, less intensive ultrafiltration. And we clearly think that this, we need further research to validate the dosing of fluid removal on outcomes. And we are currently looking at this, doing an analysis on the renal cohort to try and see whether we can validate this dose. With that, I'd like to conclude, and I'd like to acknowledge a number of people, including Professor Pilavsky, who's sitting in this audience, and Professor Kellum, and some of my fellows, and this from the Center of Critical Care Nephrology. Thank you.